I am Dr. Stephen Rice, and I serve as the president for Phi Beta Sigma chapter, also known as the Los Angeles Sigma. As a chapter, we continue to live out our principles of brotherhood, of scholarship, and service by being a voice in our community and to expand the circle so that others in the community may be educated on things that are going on. And as we know, sickle cell impacts the African American community, and we often are the ones that know least about it. And so we're excited in this month of a sickle cell awareness to bring this information to you all. So, as we continue to learn and grow as a community, let us be supportive of one another through knowledge, through advocacy, and through support. And with that, I turn this over to our own brother Tazwell. And again, welcome everyone.
Hi, thank you, Brother Rice. I appreciate that. I'd like to take the time to welcome and introduce our panelists. My wife, Dr. Shenise Gilyard, an interventional radiologist at UCLA, and the founder of Lucstrong Foundation, along with his wife, Stacy Bodden, and the parents of Luke. So thank you both for being here. We really appreciate your advocacy and just partnership during Sickle Cell Awareness Month. So I'm just going to pause and Shanice, if you don't mind, just giving us a quick blurb about yourself, and then we'll do the same for Matt to turn it over to you as well.
I'm Shenise Gilyard. I'm an interventional radiologist at UCLA Health.
And I'm Matt Bodden, co-founder of the Lucstrong Foundation, along with my wife, Stacy. We founded it in 2017 to honor our son, Luke, who went to heaven at the age of 10 due to complications of sickle cell disease. And now we partner with 17 children's hospitals across the nation and helping other children and families like our son, Luke.
All right. I'd like to thank you both for being here. So today we're going to start a panel discussion, and we thought what better than to get the perspectives of not only of parents and children living with sickle cell, but also physicians to get a broad perspective of this disease that impacts the minority community. So with that being said, we'll go ahead and dive into the panel discussion. So as far as a baseline, I think it's important to understand sickle cell disease. So Dr. Gilyard, could you explain just in simple terms what sickle cell disease is and how it affects the body?
Glad you asked. I'm actually going to do a small PowerPoint presentation just to give everyone a visual because as a radiologist, I'm a visual person. So I'm just going to briefly discuss. Everyone can see my screen.
Let me stop sharing. Yes, we should be able to see your screen now.
Okay, great. And so I'm going to I have no disclosures, but if anyone wants to pay me, I'm happy to take some bribe later. Sickle cell disease is an autosomal recessive inherited disorder. So the best way to think about it is if half of mom's body can carry the trait for sickle cell and dad's body can carry the trait for sickle cell. If they have four children, statistically, one child is going to have sickle cell disease. The other child is going to get half their genes from dad and one half from mom and will carry sickle cell trait. Another child will likely carry half the genes from mom, half the genes from dad, have sickle cell trait. And then one child might get half of this and this half and end up with no sickle cell trait or a typical blood disorder. There's a lot more complexity and nuance for the subtypes of sickle cell disease, but as you're kind of understanding it from maybe not a physician perspective, this is a great way to kind of have a mental picture of how someone might acquire the disease. So why are we talking about this?
The big question is, why do we care? So unfortunately, sickle cell disease has a low life expectancy. Nationally, for a healthy adult in the US, life expectancy is between 70s and 80s. We're closer to 80s now. But for sickle cell disease nationally, it's 56. And for California, it's 42, which is really unfortunate, especially for us in California, because that means that we're not doing what we need to be doing as a state to improve the quality of life for these patients. The most common cause of death for patients is infection, which is usually precipitated by like an acute pain or chest crisis, and that accounts for about 30% of the mortality in sickle cell disease. The problem is we don't necessarily know what caused the acute chest syndrome in a lot of these patients. So some patients just come in and they're extremely sick and they have trouble breathing. One thing I want everyone to know is it's a disease that affects every part of the body. So in medicine, we call that a systemic disease. These are my very, very advanced drawings that I did. So the sickle cell disease affects every single thing in the body. With the brain, it can cause basically mini strokes due to a vascular problem called moyamoya. It can cause blood clots to form in the lungs. It can also cause acute chest or even small areas in the lungs where they have had almost strokes or heart attacks in the lung. So it's more of a lung attack where part of the lung that is supposed to breathe in oxygen doesn't function anymore. And then it also affects the bones. So the bones can basically infarct themselves and then they collapse. And then over time, because patients are extremely anemic, the bones can have a lot of bone pain because their bones are trying to make blood cells where they don't usually make blood cells. But there are emerging therapies. So there's creative interventional pain, which I'm working on. There's a lot of medical advances, especially over the past 10 years. There's some emerging drugs that have been on the market probably since 2019 that do reduce the number of pain crises. Some patients have pain crises like on a monthly basis, and there are some drugs that are shown to significantly reduce that to maybe once or twice a year. And then there's genetic editing that is still emerging and under investigation to eliminate the disease. One of the biggest issues is access to some of these things is very limited. For example, the genetic study that created a lot of buzz last year, everyone estimates that the cost is about $1 million to $2 million per patient, just for that therapy alone. And the out-of-pocket cost for families, it could be astronomical. There are some surgical advances, like with modern joint replacement surgeries, that can help with pain as well in the bones. So, not all bad. There's a lot of hope. We need to continue family support, with organizations such as Lucstrong, research support, because there are medical breakthroughs happening every day. But currently, research funding is under siege. And we need to hopefully try to donate to organizations that support research outside of federal funding, especially for patients that have sickle cell disease. And then clinical support. One of the most important things we can do is educate doctors on how to treat patients early in the disease process, especially doctors who don't see sickle cell patients all the time. That was a quick overview, and then I'll pause.
All right. Thank you, Dr. Gilyard. I will go back to sharing. And so, one, thank you for that comprehensive overview of sickle cell. I'd like to move forward to the panel and get a perspective from a parent for a child with sickle cell disease. When did you first learn that Luke had sickle cell disease, and what was the initial experience like? And how does a sickle cell crisis feel, and how did that impact Luke's day-to-day life and your life as a parent?
Yes, well, with Luke, the new birth screening that's done for all children who are born now was done after he was born, and probably about a week after he was born, we received the news that he did test for sickle cell disease, which was a complete shock to us because we had two children prior to Luke, our son Shade and daughter Taryn, and they both, didn't have the disease. They just had the trait compared to what Dr. Gilyard showed. And so, during Luke's pregnancy, we prayed for a year before we had him. And then of the three pregnancies, it was the most peaceful, my wife says. And then 1 week after he's born, we get the news that he has sickle cell disease. I was working at the Walt Disney Company at the time and driving home to my wife after she told me. And the thoughts that ran through my mind were unsettling. Would I ever be able to throw a ball to my son? What's his life expectancy going to be? What's his quality of life going to be? Of course, your mind just goes to the extremes, and so it was extremely unsettling for both me and my wife. We never expected it, never imagined it. So it was a great shock. And in terms of a sickle cell crisis and how does it feel, what was interesting is that Luke never really experienced a sickle cell crisis, pain crisis. And so that was a blessing. For the first 7 years of his life, he never had one. But I can actually personally tell you how it feels because although I carry the trait, I'm one of the unique 5% that carry the trait that has experienced a sickle cell crisis when we go over elevation of 8,000 feet or above. So when I was in college, I used to ski and go to Big Bear every time it rained here. And so for those 4 years, I was always up there. And unbeknownst to me, I experienced a crisis, didn't know what it was. Of course, the doctors didn't know what it was. Woke up at 3 a.m. in pain, just out of my mind. My brother had to literally carry me physically. A grown man had to carry another grown man into the hospital because I was in so much pain. And they shot me up with morphine, and I woke up a day and a half later. And then it happened at least twice over the 4-year period. And it wasn't until the third time that it happened that I went to a doctor who had studied sickle cell disease in New York, and he figured out what it was and that I was a part of that 5%. So as far as how it feels, those doctors explained to me that it's comparable to a woman having labor pains. And I've never had a child, of course, so I take their word for it. But it was to the point to where I literally could not walk as a grown man. So in terms of how it feels, that's how it felt.
I appreciate that perspective, and I definitely learned something new here. Just to both of you, what are some stereotypes that sickle cell is exclusively a Black disease? And, how does this affect our community and the broader understanding of this illness?
Well, thanks so much for sharing that. And first off, I think a lot of the stereotype is just like the news and popular, things and what we know in the United States, because the largest population of people who are carriers happen to be those of the African diaspora. But the disease and the trait is very common in people in like kind of sub-Saharan Mediterranean climate. So Mediterranean folks often carriers, as well as there are significant people, like group of people that are, South Asian, that Indian that also are carriers. And so one of my colleagues in the sickle cell program at UCLA actually lost her sister to sickle cell disease. And she is an Indian American. And so I think one of the things that it's sad that we could to help with increased research funding is to also bring it up to a larger community and inform people that yes, it does disproportionately affect us in the United States, but it's still a global challenge.
From my perspective, in terms of how it impacts those who are Black, one, and correct me if I'm wrong, Dr. Gilyard, but the comparative disease for Caucasians is cystic fibrosis. And when you look at federal funding for cystic fibrosis, there's a great disparity compared to the federal funding for sickle cell disease. Cystic fibrosis, they get at least 3.5% more, or 3.5 times more than sickle cell disease from a funding, which ultimately leads to more medications being researched and produced to treat those who have cystic fibrosis versus those who have sickle cell disease. So from that standpoint, that stereotype definitely impacts it. And then personally, us as a family, our child, Luke, when he was at 7 years old, qualified for a bone marrow transplant at Children's Hospital Los Angeles. And they told us to prepare for about 4 months, basically. And so we were prepared financially for that, but because the first one failed and he had a second one, he wound up spending 11 months in the hospital. 6 months into it, my wife had to come off of her job because she was there every day, along with me, interchanging every other day, and lost 33% of our household income. But of course, those financial commitments are still there. So when we looked for organizations to help, thankfully, our church came along at the time and helped some. But when we looked for other nonprofits to help, we found a lot for cystic fibrosis, a lot for cancer and other diseases. But because sickle cell primarily affects Blacks, there were literally none. And that's when God put in our heart that if we ever had the opportunity, that we would start one. And that's what we did subsequently after he went to heaven, a year after he went to heaven. So those are just two ways in which that stereotype impacts those who have sickle cell disease within the Black community.
All right, thank you both. What I wanted to do now, as far as the panel discussion, is get into treating sickle cell disease. So, Dr. Gilyard, what are some effective treatments currently available for managing symptoms, and what are some curative options, and how do newer therapies like gene therapy and stem cell transplants offer hope for the future for patients dealing with sickle cell disease?
Thanks so much for that. Vernon, do you mind if I just share the screen really quickly? Because I have a slide that really highlights what Matt just mentioned. All right, can you see my slide?
Yeah, if you
Hello?
put it in presenter mode, it'll go full screen for us.
Okay,
And then
great. So
both
you
of
can
you
see
should
it.
be able
Great.
to share at the same time if you'd like.
Oh, cool. All right. So essentially, this is just like a graph that kind of compared funding, exactly what Matt said, comparing sickle cell disease and cystic fibrosis. And this is kind of the blue line of like the life expectancy of cystic fibrosis versus sickle cell disease. It kind of varies, but you can see that the plateau or like the peaks basically for cystic fibrosis is just like astronomical because there are accredited centers for cystic fibrosis. And unfortunately, as the trajectory is very affected by funding, there was a Sickle Cell Treatment Act, but then NIH funding for comprehensive sickle cell centers ended in 2008. So that, continued, rise in life expectancy that was hopeful for beginning, in the early 2000s has kind of plateaued off. And as, the data will show that cystic fibrosis has like all these accredited centers, pathways, and everything else to help support funding. So I'm going to stop sharing here and just kind of go back to the treatment paradigm. So the mainstay of treatment for patients that are in crisis. So there's two kinds of things. So there's like prevention of crises, and then there's also treatment of crises once somebody has a crisis. Treatment of crisis is predominantly supportive care. And what we mean by that is patients will be admitted to the hospital. They'll get IV hydration, IV pain medicine, like Matt said. It's often narcotic pain medicine. It's a mixture of different pain medicines, but it's often that. And sometimes antibiotics. The patients will undergo a lot of testing and imaging, especially chest imaging, to see if there's any concurrent lung infection that might need to be treated with antibiotics or additional respiratory support. As far as prevention, there are a couple of treatments. One of the oldest treatments for sickle cell disease is something called hydroxyurea or Hydrea. A lot of sickle cell patients are on the drug. It's a very old drug, but what it does is it basically increases something called fetal hemoglobin that reduces theoretically the number of pain crisis patients have and reduces the percentage of sickle cells or avalanche-shaped cells that are in somebody's bloodstream. There's a lot of other drugs that are targeted at that goal, which like either changes the shape of cells, which is a new drug that came out in 2019. But then there are also other drugs that are trying to even like do gene editing and change the genetic code. But that is a process that's similar to a bone marrow transplant, where it's an autologous transplant, change the genetic code and you give somebody their transplant back. So that's a very involved process where patients can find themselves in the hospital for 2 years.
And so as far as being a parent and having a child with sickle cell disease, what challenges did your family face? I know we talked about some of the hardships with just the initial perception of understanding that Luke had sickle cell disease. But like as far as medications, appointments, and hospital visits, and what kind of support did you have readily available within the healthcare system and abroad?
So our experience was during his first year, he was primarily at Children's Hospital Los Angeles, and then for the following 2 years, he was treated at UCLA Mattel. And yeah, to a large degree, I mean, there's quite a significant degree of support. The challenge is, and what we continue to see is that because of the amount of appointments, right, and the length of hospital stays, it's very difficult for the primary caregiver to maintain employment. And then when you look at the Black community and we see these applications come to us, a good percentage are single family households to where the mother is present and caring for that child and the other children. And if she then can't keep employment because of the amount of the medical care that's required, then it becomes really challenging. And so what we consistently see with the applications we receive primarily is, to a large degree, a lot of financial insecurity, a lot of home insecurity, families who are living, who are homeless or living with other family members, things of that nature. And so it's really, really challenging. And I don't think there's a window into that experience, and it's not talked about enough, how it impacts families. Thankfully for me and my wife, we were both employed, right? And then when she had to come off her job, at least we had my income, which still wasn't enough. But I could only imagine if we were a single family household and she had to come off of her job in order to provide, how she could have, you know, met all the financial needs that the family had. So that's primarily some of the ways and what we experience and what a lot of the families experience.
Yeah, I appreciate you both sharing. And to both of you, what are your thoughts for the stigmas and misinformation surrounding pain management and use of opioids for sickle cell pain? Um, I personally can like share a snapshot. I don't want to steal anybody's thunder, but like I've had the pleasure of like working with my wife and someone near and dear to her heart that she was helping with sickle cell. And I was appalled at how he was treated going through crisis at the hospital. So I can only imagine that, you're hurt, you're asking for help, you're looking for some form of remediation or assistance, and you're met with adversity, in addition to like having to maintain your composure and still ignore other people's ignorance. So, like, what has been your perspectives just dealing with loved ones with sickle cell?
Um, I'll start and then I'll pass it off to Matt. So my perspective, yes. So like, I mean, I've had multiple patients have security and the police called on them while they were in crisis because they were by themselves. They were in a lot of agonizing pain. They were young Black men and people thought they were threatening or drug seeking, and they were truly put on 5150s or put in jail or tried to be put in jail. And when I do like dinners with patients that are adults and sickle cell, have sickle cell, and I'll ask like, how many of you have been, told that you were drug seeking and like your pain was not believed? Every single person at the table will raise their hand. And so the stigma around opioid use definitely is not to the benefit of patients that have sickle cell disease who have incredibly high tolerance. Most of them are on chronic opioids for pain. And the only way you can honestly get around it is having specialty centers where they're used to treating these patients, right? Like, so cystic fibrosis, if you have a cystic fibrosis exacerbation, there's hundreds of centers that are accredited, specifically nationally accredited for cystic fibrosis. Cystic fibrosis patient comes in, they're sick, they have a whole pathway and protocol. Pulmonologist comes down immediately, manages their crisis, manages everything. With sickle cell, patients come into different emergency departments. They don't have organized care. And so it's a kind of a roll of the dice what kind of doctor you're going to get when you show up.
All right. Thank you, Dr. Gilyard.
Yes, from my perspective, I can't really speak into that experience because our son Luke, he went to heaven at the age of 10. So whenever he was treated, of course, we were there advocating for him. And to a large degree, all of the doctors that we saw, they had significant experience with sickle cell disease and were specialists. And so they knew exactly how to handle whatever challenge he was facing. But we were definitely informed by many of those doctors that where the challenge does come into play is once he turns 18 and becomes an adult, right? And he's then being seen by non-specialists. They did point out, all of the challenges surrounding pain management and the stigma surrounding it, and how many times, they're just misdiagnosed and not understood. And so even for us, even though he never experienced that because he never got to the age to experience it, it was definitely a significant concern and a consistent conversation between me and my wife. Like, yes, he's getting great care now, but what will happen when he turns 18? And so that was definitely a significant concern for us.
All right, thank you both. I just wanted to turn to the chat. There were a few questions that came up that I'd like to acknowledge, and thank you, Dr. Gilyard, for answering those promptly. So, Dr. Falls asked, families impacted by sickle cell disease require excellent healthcare specialists. Do we see families relocating to be near these specialty centers? Dr. Gilyard acknowledged that that was an amazing question and provided that the University of Alabama, Birmingham, people relocate from those remote areas of Alabama to be closer to the city. But because of loss of funding with this current administration, with the NIH support, there are challenges identifying and finding supporting centers. A follow-up question was by Brother Odie Mitchell. An acquaintance recently discovered that they have the trait after donating blood during a blood drive. The irony is that they have donated blood many times before and were never informed that they had the trait. They are over 55 years old. If you know, is testing for the trait a new Red Cross initiative? And should African Americans just test for the trait, especially if they are planning to get married and have children?
I think that's a great question. I didn't know about the Red Cross initiative, but I think that's really interesting and not surprising that a lot of people are silent carriers. That's why a lot of primary care doctors and especially OBGYNs and maternal fetal medicine physicians do encourage testing for couples, especially in the planning phase, if they're trying to conceive, just so that they can go in armed with knowledge about the risk and then also prepare themselves if someone finds out that they have a child with sickle cell.
Thank you, Dr. Gilyard. And so now we'll move into the final portion, just kind of talking about living with sickle cell disease. And so both of these questions are an open forum. But what we would like to ask are, what are common mental health challenges for individuals who are living with sickle cell disease and their families? And how can someone help manage the anxiety, depression, those residual effects that come with chronic pain and hospitalization?
Well, for us, in regards to our son Luke, he never really experienced depression, most likely because of his age, or anxiety. But in terms of his experience, once he received the bone marrow transplant, and then for the next 3 years after that, how it impacted his immune system. He spent 11 months at CHLA in one room, only being able to see us family members. And then every time we entered the room, we had to have on full scrubs. So he celebrated birthday, Christmas, everything in that one room, only being able to see us. And then once he got out, they didn't expect him to live. By the grace of God, he survived. To the point to where when he walked out of there, the nurses nicknamed him Lazarus, because they literally expected that he was going to die because he experienced the most significant complication called graft versus host disease. And there's 4 stages to it, kind of like cancer, and he experienced stage 4. And because of it, they did not expect him to live. And so when he walked out of there, the head doctor, Dr. Mahadeo, turned to me and said, "Mr. Bodden, it's a miracle that your son is alive." And naturally I replied, "Well, that's what my Lord and Savior does. He performs miracles." And so, but the next year, practically, he, for the most part, he really couldn't even go outside, right? On eggshells to a large degree because his immune system was so compromised. And so, of course, that definitely impacted his childhood, his perspective on life. But by the grace of God, man, he was a strong, strong boy. And it's amazing. It's amazing how he dealt with those, I mean, challenges that he experienced, which literally he nearly died at least 3 times during that 3-year period, prior to God calling him home to heaven. And he handled it phenomenally. He was truly strong the way God designed him. And but yeah, it definitely impacted him significantly.
Yeah, and having such wonderful parents helps a lot. As you kind of alluded to earlier, Matt, a lot of kids are coming from single family homes, folks having a child with a chronic illness is sadly statistically extremely stressful on families. And so it can be a very difficult cause of friction between couples and results in separations or divorces. It's very common, regrettably. But one of the things that one of my mentors does is she does a lot of neurological and psychological testing, especially for those teenagers that have chronic illness, especially sickle cell disease. And one of the things that happens over time is, like, as I talked about at the beginning of the presentation, is people with sickle cell can often experience very micro strokes, which can unfortunately affect your mood. And so that's like one of the things that we don't even think about, but like some of these micro strokes can really make you feel like have, depression and other things. And also being in chronic pain, we know is linked to having symptoms of depression because your whole system is heightened. And so there's not a lot of serotonin to override all of the pain that you're in. And so for us, I recommend multimodal support, so psychological, support, neurological pain support, and then family support, but also supporting the families and caregivers who are going through this pretty difficult and traumatic experience as well.
Thank you, Dr. Gilyard, and thank you, Matt. So my final question for today, before we open it up to the rest of all of our attendees here, could you share some ways you assist your loved ones and patients dealing with chronic pain and the unpredictability of the disease? And how do you advocate for them in a medical setting, especially in the emergency room?
Yes, from my perspective, us being present, that was the primary way that we advocated for our son Luke. When he was in the hospital for those 11 months, there was literally not 1 minute that he did not have either my wife Stacy or me by his side. And that's 24 hours. So my wife would spend the day and the night, the day there, then I would get off of work, come there around 6 p.m., and then stay the night and the rest of the day and work remotely from that room. And then she would come to relieve me the next day around 6 p.m. And so we did that for 11 months. And so from that standpoint, we were able to advocate for him in that setting. And then, as much as we respect doctors and we respect their knowledge, if we ever suspected that he wasn't being treated correctly, we held them accountable. And to the point to where, because we advocated for him from that standpoint, there were certain protocols that were actually literally changed at CHLA because of some of the ways that we advocated for him and challenged some of their protocols. So it's just, by the grace of God, we're able to be there present for him and to advocate for him.
All right, thank you, Matt. And Dr. Gilyard, did you have any closing remarks as far as how you? Oh yeah.
I'm sorry. Yeah, I was just going to echo what Matt said, that yes, if you have a loved one in the hospital, make sure they know you're around, because that advocacy makes a huge difference. It doesn't even matter at my big old age being a doctor. I still wanted to make sure Jordan and my mom were present when I had to go to the hospital, because I didn't even trust them with me, despite all of my insider knowledge. Dr. Beverly Falls made a comment about experience with some of the youth groups that provide support. And yes, there are definitely there's a sickle cell camp that some of I call them my kids, but they're young adults, have gone to. And it is a meaningful experience for them. And they often hold on to those bonds pretty tightly.
All right. Thank you so much. And thank you, Dr. Falls. So what I like to do now, if there are any questions, this has been a great forum, and we have a lot of thought leaders here. So if you have any questions, comments, or just want to pour love into both Dr. Gilyard and Matt, feel free to come off mute or put a comment in the chat.
Yeah, I would suggest to raise your hand. That way I can navigate and make sure folks are good. But I'll kick us off with a question. My question is, I know that the United States healthcare system is trash in terms of the expense that comes along with medical care. So I'm wondering if you know what other countries are doing in terms of uh, this disease, if there's any other headways, if the medicines are cheaper, or there's other things that we're not doing here that other places are.
Brother Dr. Theo, that is a massive question. And yes,
My bad.
so it's difficult to discuss like the differences in sickle cell care because a lot of the sickle cell information that we have coming out of here in Africa, they don't have the same access to like the more new technological advances in health. What I will say is that in the United States, the basis of our challenges arise from the fact that healthcare is considered a privilege, and around the world in most countries, develop like irrespective of their stage of development, it's considered a right. So, with our sickle cell patients, I will say one thing that they do have is because they're chronic illness, even after they turn 26 and are off their parents' healthcare, they still qualify for Medicaid. But the challenge then is finding doctors that will take Medicaid. And so some of these sickle cell centers have exemptions to take Medicaid, which they would not ordinarily do for other patients and diseases because the reimbursements are so low. But that's one of our biggest fears right now because there's new cuts coming to Medicaid, AID, that is kind of scaring pretty much all the centers that take care of patients that have sickle cell disease and other patients that happen to look a lot like us, because the funding for those hospitals is going to precipitously decline, and we may not be able to provide the same level of service as we have been.
Are there any other questions? Because I have one, but I do want to open it to the forum before I'm a little selfish. So Matt, I again, I've helped Shenise and like had the privilege of seeing some of her patients that she cares for with sickle cell. How do you keep calm knowing the adversity and seeing the mismanagement of care? Like, I don't know, we're both Christians, and so we do share that bond, but like, how do you keep yourself grounded in the moment of adversity when a clinician who's supposed to take care of your loved one wrongs you in that moment? How do you reset yourself and focus on the priorities?
Um, Definitely through scripture and prayer. When our Father in heaven says, forgive those who treat you wrong, or that I won't forgive you. So first and foremost, that's always present in my heart to forgive first. And then for me, just my daily devotion, anchoring my mind and heart in scripture. During the time that we were fighting for his life during that 11 months in the hospital, was still taking my time in the morning to step away from the room when he was asleep and go downstairs and find a quiet space and still do my devotion, so I can. And that's one of the Psalms that I've meditated on and read through every day was Psalm 33. And even now, that's the foundational Psalm that you'll see in all of our all the clothing and the product that we do. And so from that standpoint, that's how I was able to deal with it because, every morning we would have a battery of reports being presented to us by maybe 6 different physicians. And in his case, because it was graft versus host disease and he was fighting for his life, those results were always extremely negative and pointed to him dying. And so I primarily was the one who took those meetings when they came in the morning. And yes, I had to be prayed up. I had to be worded up. And that's how I was able, and me and my wife and family were able to deal with, the out of this world challenging news that we received on a consistent basis.
And yeah, that's very wise, Matt. And as a Christian from the south side of heaven, I am more likely to shake tables and cause chaos and calamity, but you can't really do that in the hospital because that unfortunately stigmatizes you and your family. And so the prayed up method is probably the best way to prevent you from getting security called on you. And then in the chart, they will put aggressive, like it'll be a red buzz, and then everyone's on height and stuff, and then it really reduces the quality of care. So even if you really want to crash out, and rightfully so, it actually is extremely hurtful to your own care. It's like detrimental because yes, I did say the south side of heaven. I did.
Yeah, and I'll add to that, as I said before, even though I operated from that standpoint, when it came to holding them accountable, we did to the level to where they literally changed protocols because, yeah, we talk about that South Side. Yeah, I grew up in South LA in the 80s, and
Exactly.
so when we had to advocate, we advocate, but in a way that would cause them to create true change, basically. And that's what happened, and that's how we operate. I mean, we're always interested in pouring our energies and our emotions into creating true change. That way, it can help others going forward.
Yeah, and then don't be afraid to keep going up. There's always someone above whoever. I mean, we all know who the ultimate one is above, but there are people that are above at every level of the hospital that you can engage in if you feel like you're not getting the care that you deserve.
All right. I have an additional question. I mean, it seems like, we talked a little bit about the family structures and the amount of time it takes to support someone that's going through sickle cell disease and rising to the occasion. Like, what are some things that folks need, like either as families, like while they're going through this experience? Like, I know when I think about other diseases, sometimes it's just like blanket drop-offs or food trains or different types of support. So like, what are some things that you think specifically families that are going through this experience could use support from organizations like ours? I know we can donate to research and things like that, but like I know a lot of brothers are kind of boots on the ground, like wanting to help and give a helping hand. Like, what are some of those types of things that you all think could be helpful?
Yeah, well, for us, our foundation, the Lucstrong Foundation, I mean, we're community based. So you talk about boots on the ground, because we're primarily donor based. We actually host 4 fundraisers a year in our community. And so we do 2 pickleball fundraisers, 1 kickball fundraiser, and a gala fundraiser. And in terms of boots on the ground, it's being a part of those events, right? So at our pickleball fundraiser, we had about 300 people in the community present. At our kickball fundraiser, we have approximately about 400 present this year. At our gala, which we just had about maybe 3 weeks ago, that Dr. Gilyard and my brother Jordan attended, we had approximately about 150 people there. And so talk about boots on the ground is definitely being a part of those events, being present at those events, and then contributing to the foundation, and then ultimately we then contribute directly to the families, right? I don't know of any other nonprofit, and we hear this a lot from, because we work primarily with the social workers who oversee the oncology department that the sickle cell patients and families go through. And they say not in comparison to other sickle cell nonprofits, because there's very few that do what we do, if any at all. But compared to all nonprofits, they say that we give the most as far as grants to these families. And that's compared to cancer nonprofits, cystic fibrosis, that we give the most. But that's because it was a lived experience for us. And then we love our people. We care about our people. We know their struggles. And so that's why we give at the level that we give as a foundation. Yeah, you talk about boots in the ground. You literally touch these families when you donate to the Lucstrong Foundation or when you come to our fundraisers.
And honestly, it's so much money taking care of someone who's sick for so long. It is a huge thing. So sometimes, like patients and families, if you can, like, if you know a family that's going through something like this, blessing them with $100 would be massive. Or even being like, pick up the kids, like the other kids, because they have other kids that might need get school still happens, school drop-offs, school pickups still happen. Like all the life things that happen when it feels like time is frozen continue to happen. And that is like one of the things, like a village to support families like this is so important. And the families that have villages just are able to weather the storm a lot better. And so if you know someone that's going through chronic illness, like just be their village and just like be like, name like 5 things that you need. Honestly, like don't forget, at half these hospitals, it's like $18 a day to park there. So if you're spending 11 months there, that's like an unfathomable amount of money just on parking at a stupid hospital that you're paying $7,000 a day to go to.
I couldn't have said that part. We use that example so many times. The
Unreal.
parking costs at CHLA or at UCLA when we were there for those, it's unimaginable, unimaginable on top of everything else that you're paying for. It's ridiculous. And so, yeah, so that's a part of our program basically is, and that's why when we give our grants, we give it in a way to where the families can use it however they want to use it. It's not restricted to any specific bill, and you don't have to provide us with any specific bill because when we were on the other side of it, and we're fighting for our children's life, right? And we're applying for a grant from some nonprofit, and they might have given us, a few $100s. Then we have to provide them with the exact bill, and I'm fighting for my child's life. I don't have time. I don't have time to to provide you with support for how we used, the few $100s that you gave to us.
The pennies,
Parking.
thank you.
Yeah. But yeah, that's one of the examples that we consistently use. And that's why we structure our grants the way that we do, so the families can ultimately use it to cover their medical expenses, parking, food, housing, whatever critical needs they have, they can use it toward it.
Thank you both. Again, I've met Matt at my church, Fairview Heights Baptist Church in Inglewood, and I've had the privilege of participating in the Lucstrong Foundation, specifically the kickball tournament, and most recently the poker tournament. And so we do have displayed an opportunity for you to donate. I will personally be donating on behalf of the Phi Beta Sigma chapter of Los Angeles $250 to the Lucstrong Foundation. And if it is in your heart, or if you have the ability to, we will have this QR code up for a little while as we continue the discussion. I know it was supposed to go to 4:45. We're a little bit past, but we'll keep it going as long as Dr. Gilyard and Matt are available. But the last thing that I wanted to highlight was Dr. Falls mentioned, again, with our current political climate that we're in, acetaminophen, also known as Tylenol, which is meant for pain management, being taken out of our common access. So either Dr. Gilyard, Dr. Falls, or anybody else on the forum who wants to share their perspective on how this could impact our crises with sickle cell and other chronic diseases that we're dealing with.
I like to say that I very much appreciate this forum, compliment the Sigmas for their excellent work and Dr. Gilyard for her expertise. As you can see, we have to be the ones to do this work. And in my former practice, I'm retired as an OBGYN. I did have the privilege of taking care of a young woman who was pregnant that had sickle cell. And even without sickle cell, in the healthcare system, we are consistently treated as if we don't feel pain still. And that is a issue. That is a problem. And now we have, I don't want to curse and I don't want to call anybody a fool, but people saying don't even take Tylenol when you're in pain and you have a fever. So listen to your doctor, work with your doctor, teach your doctor, and don't listen to these people that are taking away our health care.
Yeah, we're going to be fighting a crisis of disinformation for a long time. And especially just on the vaccines issue as well as Tylenol. There are certain places now, Florida doesn't require vaccines for children. And so where that impacts us is like for a child that might be going through a bone marrow transplant. I mean, in addition to them not going outside, they cannot go outside, and neither can you, because nobody is protected from diphtheria or measles. And measles in a person that has no immune system would be immediately deadly. Like something I personally have never seen before. I hope to never see it again, ever in my lifetime, but I have a nagging suspicion that I will probably see measles in someone who has an immune system in the near future. And that terrifies me because I've never, even you, I don't think you would have not learned how to treat measles because it was eradicated before you started medical school. Like, so none of us know how to, like, there's 3 generations of doctors who don't know how to treat measles because it shouldn't have been a problem.
Again, I just want to thank all of you for joining. This has been an impactful experience, and this won't be the last time we have this discussion. And I hope you have a wonderful weekend.
Awesome.
Thank you, guys.
Thanks so much, everybody. Have a great day.